New strategy is webinar, blended learning, and e-learning. ANBIIG webinar series were held from July to December 2020 during COVID-19 era. So we have many webinar series like this. I can't explain one by one. But anyway, global coverage, majority of attendees from all over Asia. And further enhancement in 2021 and 2022, multi-center blended learning. That means online lectures by overseas members, clinical case sharing by local members and trainees, concurrent hands-on practice at individual local training facilities. And the other thing is self-learning, recorded lecture video, NBI quiz, e-learning module for Catholic IEE. Blended learning, this slide shows blended learning. Short lecture on ESG technique. So we will repeat the step and improve the skills. This is also quite exciting trials. So we are also giving tele-mentoring, local hands-on stations connected to overseas facility for live teaching. It may be quite challenging, but it's done. So, accordingly, our training coverage in Asia Pacific from 2013 to 2023, 158 ANBIIG workshops were conducted in the world. It's surprising. And 16,000 more trainees completed the training. It's a big achievement. So this is a footprint, so we can't explain each footprint. Perhaps as you can see, there's many workshops here. So throughout Asia. Okay. So some of our milestones. Our publications illustrate the effectiveness of standardized training methods. We have a poster presentation at DDW, oral presentation and publication at UGW, free paper prize, and abstract articles is submitted to GIE 2015. And the other one is effect of standardized training program on endoscopic diagnosis of early gastrointestinal dysplasia. So we have made a presentation in official congress regarding standardized training method. And we have developed training model. This is a column, Jenny model, for practicing colposcopy insertion and enhanced image capturing. And this is also quite nice achievement of ours. We collaborated and made huge discussions in order to construct first diagnostic endoscopic guidelines in Asia for upper GI and lower GI. So we made a quite big effort, and consequently for upper GI, the manuscript was accepted by GATT. This is quite major journal, and we think this is a great achievement. For lower GI, it is accepted by digestive endoscopy. It is official Japanese endoscopy journal. So, and we also planned to book publication. So this is a completed book. So endoscopy in early gastrointestinal cancer, volume 1, diagnosis, volume 2, treatment. It was published by Shikima. So it is also very nice milestones. So development of also quick reference guide for LBI classification. PDF information available for free of charge. via ANBIIG website. Do you need this time? No? Yeah. If someone wants, we are happy to send it. So, otherwise, you can download it. Please put them in your endoscopy book for reference. And in addition to endoscopy, completion of clinical chain training by introducing pathology sessions. We invited famous pathology doctor from Japan, Mongolia, Japan, Philippines, GS pathology webinar, and so on. So we constructed new ANBIIG website, www.anbig.organization. Please visit our site. There is many lecture videos and NBA quiz, e-learning on gastric IUE. It's quite efficient. All of them are free of charge and self-study materials. Thank you for your kind attention. This is it.
Thank you for your interesting presentation, Professor Jeong. And I think all the doctors know about Professor Jeong and his huge contribution in early gastric cancer so far. And I think all the doctors in Vietnam who want to learn about the early cancer have to know the Professor Jeong. And we will start our morning section with the first lecture from Professor Jeong. He will do a short summary on how to diagnose early gastric cancer, then share one gastric case to diagnose together.
Thank you. Thank you for your kind introduction. So, the time is quite limited, so I will only make a presentation of principles. So, regarding how to diagnose early gastric cancer. This is my main theme in my life. Okay? Endoscopic diagnosis of early gastric cancer is divided into two steps. That is detection and characterization. So if you want to take a picture, please don't hesitate to take a picture for your memory. I don't care about it. Okay? So I'd like to talk about detection. For the detection, the most important thing is giving the patient ideal preparation. This is a common sense, but fasting since dinner the last night before, and in the morning of endoscopy gives a prep solution. In Japan, 100 ml of water with mucolytic agent, that is Pronex, deforming agent, that is dimethyl. So without this, we can't detect early gastric cancer. So if Pronex is not available for mucolytic agent, acetylcysteine can be alternative drug. So please do this. If just only 4 drops of simethicone plus 200 ml water 30 minutes before EST, the stomach is totally different from without simethicone. Just quite simple thing. So this can be the most important thing. I've been to many countries, but unfortunately, many countries do not employ this preparation. If you don't have Pronex, just 4 drops of simethicone should be alright. It's cheap. Everybody can do it. Are you giving patients simethicone?
Yes.
Good. And regarding technique to avoid blind spots are next important things. The basic techniques are distending the gastric wall by air insufflation. in order to detect, in order to reduce the blind spot. Of course, releasing mucus flows from the gastric mucosa through irrigation with water and deforming agent is also important. But time is limited. I will focusing on how to map the entire stomach. So this is also common sense, but it isn't standardized in the world. Traditionally in Japan, we follow a systematic screening protocol for the upper GI tract. However, no standardized protocol has not been established. The problem is that each procedure takes more than 40 pictures in Japan. We need to establish a minimal required standard which can be applied worldwide. Therefore, I made a proposal of systematic screening protocol for the stomach called SSS after discussing the worldwide endoscopists, so they can accept it. SSS comprise 22 images. So 22 images, but so it is very, very systematized. So I want to show you the example one by one. First, we apply anterior view. When we insert the scope into the antrum, I will take lesser curvature, anterior wall, greater curvature, posterior wall. This can make 4-quadrant view. Okay, it's quite easy. And if you draw back the scope into the lower part of gastric body, we will take lesser curvature, anterior wall, greater curvature, and posterior wall. It is also quite easy to remember. And then if we draw back the scope to the mid upper body, similarly, lesser curvature, anterior wall, greater curvature, posterior wall. It's quite easy to remember. So this is anterior view, and then we will go to retroflex view, and then take a fundus cardia area, greater curvature, anterior wall, lesser curvature, posterior wall. It's 4-quadrant view. It's quite easy to remember. Keeping the retroflex position in the mid-upper body, lesser curvature, anterior wall, posterior wall. It can be 3-quadrant because greater curvature becomes tangential. It doesn't work very well, so we only need 3-quadrant here. This is the last part, incisura, lesser, anterior, posterior. That's it. So 22 images seems to be many images, but if you remember or if you understand this systematized protocol, it's quite easy to remember and to perform in your clinical practice. So in the world, this SSS can be a standard procedure for screening endoscopy. But in the case of detailed examination for the known cancer, we always perform systematic screening in order to detect synchronous molecular cancer. So this can be applied in any case. Okay, please remember it. And I move on to from technique to knowledge. Knowledge for detection, we have many things to talk about, but I'm going to introduce quite representative things. So awareness of signs of suspicious lesion are very important. So I'm going to introduce which marker is useful. One, surface change. So early gastric cancer shows very, very subtle change, but we need to detect such subtle surface change and then make a diagnosis. And the second thing is color, surface and color. So gastrointestinal cancer, such as Z2A, Z2B, and Z2C, is a very, very difficult to detect. However, if you know the sign of the cancer. One is well-demarcated reddened area. So this is the most difficult regions, that is 0 to be superficial flat type. So, but this well-demarcated reddened area can be a very characteristic sign for the presence of carcinoma. Please remember this. And also, well-demarcated pale area can be a very good marker for detection. As you can see, this is very well demarcated color change area here. So it is a very good sign for detecting cancer. And third, the abrupt change in vascular mucosal pattern is also very, very useful. So this is atrophic mucosa in the gastric body, but when you trace the vascular pattern carefully, so vascular pattern is abruptly interrupted here. That means there is distinct lesion here. We are always looking at such vascular pattern, whether it is interrupted or not. So this is a very important sign for detection. Okay. If you spray dye, it becomes more clear. However, by these findings alone, we can make a diagnosis of cancer. Please remember, trace a vascular pattern in atrophic mucosa. So, such detection is the most important thing than advanced endoscopy. Anyway, if you detect a lesion, we need to characterize the lesion whether or not it's cancer. So first, we need to make a diagnosis using conventional white light imaging. So what we should do by conventional white light imaging is, it is quite simple, making a diagnosis gastritis versus superficial cancer, gastritis lesion. And you, ulcerative lesion, peptic ulcer versus superficial cancer with ulceration. It's quite simple. And P, polyp lesion, polyps versus polyp cancer. What we should do is quite simple. Japanese diagnosis system is really complicated, but I try to simplify it. Okay. So it's Japanese background. But anyway, and also propose, I noticed there is no criteria for early gastric cancer by conventional white light imaging during more than 30 years in Japan. But I propose simple criteria for early gastric cancer by conventional white light imaging. Everybody can do it. It is called color plus surface CS classification. The criteria is 1, well-demarcated lesion with irregularity in color. And 2, a well-demarcated lesion with irregularity in surface. If the lesion fulfills 1 and or 2, the lesion is diagnosed as cancer, otherwise non-cancer. This criteria has nearly 85% sensitivity and specificity. So I'm going to show some good example. This is a focal atrophic mucosa. So this is not well demarcated lesion, no irregularity in color or surface. So we can make a diagnosis, this is not cancer. But this lesion shows well demarcated lesion and irregularity in color or surface and surface. So we can make a diagnosis, this is endoscopically cancer. So for such deep-placed pale lesion, this CS classification system can be applied to make a diagnosis by conventional white light imaging alone. So as you can see, so at a glance, you can say this is cancer, but we need to apply some criteria to do some standardized diagnostic system. For ulcerative lesion, peptic ulcer versus superficial cancer with ulceration, this is just peptic ulcer. There is no well-demarcated lesion around the cancer. There is no irregularity in color or surface. So this is not cancer. However, this lesion shows a well-demarcated lesion around the ulcer, irregularity in color or surface. So we can make a diagnosis of cancer. So for such ulcerated lesion, this CS classification can be applied. Okay. And the last, GUP, pulpy system, pulpy lesion. This is just hyperplastic polyp, well-demarcated lesion, but no irregularity in color or surface. Of course, at a glance, this is particular polyp, but we should apply criteria, well-demarcated lesion, and no irregularity in color or surface. And this is ANBIIG cancer of protrusive type. This is well-demarcated lesion. Of course, irregularity in color or surface. According to the criteria, it can be diagnosed as cancer. And this is a small elevated type of cancer, well-demarcated lesion, irregularity in color or surface. So, this criteria can be applied to just conventional quadrant imaging, gastritis-like lesion, ulcerated lesion, pulpy lesion. So, most of the lesion can be diagnosed conventional quadrant imaging alone. But in the difficult case, I have developed magnifying narrowband imaging. This is also exciting procedure. I propose GS plus surface classification system for diagnosis of ANBIIG cancer by magnifying narrowband imaging in 2009 with Greece and England consensus in endoscopy. The GS classification system is quite simple. For microvascular pattern, just classify as regular, irregular, or absent. For microsurface pattern, just classify regular, irregular, absent. Just 3 categories. So both regular, irregular, absent. So it's quite simple. The criteria is also simple. One is irregular microvascular pattern with a demarcation line, and or irregular microsurface pattern with a demarcation line. So we can apply for any carcinoma, but I'm going to show endoscopic diagnosis of minute, equal or less than 5 mm ANBIIG cancer. So this slide shows irregularly shaped minute depression. I was always told by the senior doctor to take a biopsy. However, if we apply magnifying narrowband imaging, it shows demarcation line here. However, if you look at inside the lesion carefully, the polygonal capillary forms quite regular network. That means it's regular microvascular pattern. And this is crypt opening. This shows quite regular arrangement. That is, there is no cancer finding. So this is just intestinal metaplasia. I'm going to show extremely minute lesion, 2 millimeters. So this is slightly color change. And when I magnified it by maximum magnification, there is a demarcation line here. And if you look at the microvascular pattern it shows carefully, it shows quite heterogeneous. And each shows irregular shape. That means irregular microvascular pattern. And microsurface pattern also shows quite heterogeneous. And the distribution is irregular. So we can call irregular microsurface pattern. Of course, demarcation line is present. We are confident that this is cancer. And we resected it. It's 2 mm, well differentiated and carcinoma. I'm going to show minute 0 to B. Please detect such lesion in Vietnam. So this is totally flat lesion. This is my patient. when we magnify this area, this is it. So there is a clear demarcation line, and we are confident this is irregular microvascular pattern and irregular microsurface pattern. This region is very, very minute. So after taking informed consent, we don't take any biopsy and resected it. The pathology specimen shows well differentiated adenocarcinoma. We are very pleased. So generally, diagnostic performance of ANBIIG is quite nice. So in our prospective randomized control study, which was published in gastroenterology, so sensitivity and specificity is more than 95%. It's really amazing modalities. But this is prospective data, so we are confident. So, but I'd like to talk about the limitation of such magnifying endoscopy. The limitation is a pale flat mucosal lesion. This is very demarcated pale area, but when you magnify it, there is no demarcation line. There is no abrupt change. And microvascular pattern shows regular, and microsurface pattern shows regular. So that means there is no finding of cancer. However, if we resected it, it's signal-clearing cell carcinoma. Because signal-clearing cell carcinoma invade underneath the mucosa, and that can make any change in microsurface pattern and microvascular pattern. So this pale type of carcinoma, we don't need to apply ANBIIG. Instead, we need to take biopsy. This is a different strategy. Okay. Please remember, this is a very important point. In conclusion, I demonstrated how to detect and how to characterize early gastric cancer. Thank you for your kind attention.
Thank you, Professor Kenshi.Yao, for the interesting case showing and explanation.
I have one more comment. So we bring invitation letter to our e-learning for detection by conventional vital division. It is quite efficient for the people to increase the detection rate. So simply deliver the invitation letter. Please access to e-learning and see it.
Interpretation letter is the e-learning system created by Professor. There are 100 case studies in this system. And there is also the QR code that we will show here. And this is the link that you can go to.
Mọi người cùng đăng nhập vào cái phần e-learning ấy, có thể quét QR trên kia để đăng nhập vào.
Next question. Yeah.
Yes.
So did you suspect the body gastric cancer in the last case when you performed pathogen diagnostic the signaling cancer?
Yes. As I told you before, using CS classification for conventional pathology. So the one thing is very well demarcated pale region. That can be nucleus region, but it does not show any irregularity in color or surface. So I can make definite diagnosis with high confidence. So in such cases, I strongly suspect cancer because according to my experience, this can be cancer. But we can say using the diagnostic criteria. So we need to take that. So, but I strongly suspect cancer. But if you subsequently perform modified endoscopy, then no suspicious problem. This is really important pitfall. If people rely upon modified endoscopy alone, they miss it. They don't take any biopsy. So this is the point I want to emphasize. Okay.
Thank you, Professor Jeong. And I want to short speak that all the doctor in Vietnam at least one time to see so your systematic protocol poster and every endoscopy room in Vietnam, I know. Yeah. But it's the first time you come to our country, and we all of us today is very happy and lucky to hear your voice, and we are grateful on this publication, and you are published a lot of simple criteria system for detect and diagnose cancer. Thank you so much, and once again, thank you, Professor Dan, for the interesting and very detailed explanation. Thank you so much. And now we move to the next lecture by Professor Jeong-Sik.Byeon. Professor Jeong-Sik.Byeon will do a brief on how to diagnose colon cancer, and then we will also share a colon case for us to diagnose together. Please ask yours, Professor.
Thank you, Chairman. Good morning, ladies and gentlemen. First of all, I'd like to express my sincere gratitude to many Vietnamese friend doctors, including Dr. Ho, who is my old friend, and for giving me this opportunity to be here today. And it's also my great honor to be here together with Professor Yao, who is the father of the ANBIIG group. And I was also very impressed at his lecture, the systematic observation and systematic characterization method. I'm gonna talk about endoscopic diagnosis of early colon cancer. Okay. Yeah, these are what I'm going to talk about today. And why is the real-time histological diagnosis necessary? It is because It is because what is the laser pointer? It is because the treatment plan is decided on the real-time histological diagnosis. For example, we can observe hypoplastic polyp without any treatment, but adenomas and early cancers should be treated by endoscopic resection and/or surgery. Then, how can we characterize colorectal polyps in real time? We can make the endoscopic diagnosis by gross appearance evaluation under white light endoscopy observation, and by the surface vascular pattern evaluation by image-enhanced endoscopy such as ANBIIG and so on. And we can make also the endoscopic diagnosis by surface P pattern analysis under chromoscopy observation. So once we make endoscopic diagnosis of early cancer, we can decide the treatment plan. Mucosal or superficial submucosal colon cancer can be treated by endoscopic resection, and deep submucosal cancer should be treated by surgery. Now, I'd like to mention about differential diagnosis by ANBIIG vascular pattern. So this is the histological structure of a colonic epithelium, and the narrowband image, ANBIIG image, can visualize the surface microvessels here, more clearly as a brown color, like this picture shows here. Hypoplastic polyp does not abundant amount of surface vessels like this histology picture shows here. So ANBIIG image shows a lighter, brighter surface compared to the background normal mucosa because of rare surface vascularity. Since the cervical lesion also does not have abundant surface microvessels, but some areas there are thin microvessels. So basically, the general surface looks quite lighter, brighter than the background mucosa, but there are several tortuous, thin, racy vessels on cystocervical lesion. The ANBIIG image of conventional tubular adenoma or tubulobilous adenoma shows regular thickness and regularly arranged surface microvessels because of regularly arranged surface vessels in this histology slide shows here. This is a quite large laterally spreading tumor, but the surface shows very regular thickness, very regularly arranged surface vessels as a brown color. So, despite its very large size, this tumor may be benign adenoma rather than early cancer. Let's see early colon cancer cases. Basically, the surface vascularity is irregular in early colon cancer cases. So you can see quite abundant vascularity here, but there is almost near zero rare vascularity here. So the ANBIIG image also shows irregularities in terms of thickness of vessels. You can see a little thick vessels here, but these vessels are slightly narrow, relatively narrow, and the arrangement is also irregular, basically. So this irregularity in terms of thickness and arrangement suggests the possibility of early colon cancer. If the early colon cancer becomes more advanced, I mean, if the tumor is deep submucosal cancer, the irregularity becomes more severe. So you can see the higher irregularity in terms of thickness of vessels and arrangement of vessels. So these vessels are quite thick, but some areas, although it's not, because it's not zoom picture, we cannot tell exactly, but accurately. But you can see very thin vessels here and thick vessels here, and the arrangement of vessels also very irregular. So some areas show nearly no vessels. We call this avascular area, and some areas vessels are condensed, dense. So this point that the severe irregularity in arrangement and thickness, those points with occasional avascular area, those findings are very important to suspect deep submucosal cancer. So JNET classification is a strategic classification for the decision of a treatment plan. As you know, type 2A, a regular surface vascular pattern, suggests a benign adenoma rather than early cancer. So in this case, you can remove this tumor either by endoscopic angle resection and piecemeal. So the piecemeal resection can be performed because the tumor may be a benign lesion. And JNET type 2B, slightly irregular vascular pattern in terms of thickness and arrangement. You see the vessel, basically you can see vessels, but the thickness is a little different between vessels and vessels, and the arrangement is not regular like this. It seems irregular. So, but compared to type 3, JNET type 3, as I said in a previous slide, there is sometimes avascular area like this, complete absence of vessels, and the thickness of vessels is much more irregular compared to type 2B. So JNET type 2B suggests usually mucosal or superficial submucosal cancer, which should be treated by analog EMR or ESD. JNET type 3 usually suggests deep submucosal cancer. So this type should be treated by surgery. So let's see several cases showing the role of NBI in the real-time histological diagnosis. What do you think of the NBI pattern of this case? Basically, the NBI vascular pattern is not regular; it's irregular. So it may be JNET type 2B or 3. And let's see how irregular this NBI pattern is. It's quite tricky, quite difficult. I think it's somewhere between JNET type 2B and 3. But personally, we can see surface microvessels throughout the whole surface. And although there is some area, very small area without vessels, basically almost all areas show vessels, which means no avascular area. So I think it may be more likely JNET type 2B rather than JNET type 3. So it can be mucosal or superficial submucosal cancer. And because of the possibility of early cancer, I performed en-bloc pre-cut EMR. I didn't perform ESD because it was quite small. I could remove this tumor only by a pre-cut EMR, so I performed pre-cut EMR, and the final histology was mucosal cancer with cancer invasion depth up to muscularis mucosa. This is the second case. So what do you think of the NBI pattern in this case? So you may agree that the irregularity is very, very severe. So this area shows nearly no vessels, which means avascular area, and some areas are very amorphous vessels are condensed, and so very, very irregular arrangement. So this may be a JNET type 3, which suggests deep submucosal cancer. So we performed the surgical resection in this case, and the final pathology was deep submucosal cancer, and there was even positive lymph node metastasis. Okay, now let's see the differential diagnosis by laterally spreading tumor subtypes. So there are 4 LSD subtypes, and granular homogeneous LSD has nearly 0%, negligible risk of submucosal cancer. In contrast, non-granular sugar-depressed LSD has about 30% of risk of submucosal cancer, very considerable risk of submucosal cancer. And non-granular flat elevated and granular nodular mixed LSD have about 5% and 10% risk of submucosal cancer, respectively. So, granular homogeneous LSD is a good indication for piecemeal resection if MBI and p-pattern analysis shows benign region because of very low, negligible risk of submucosal cancer in terms of LSD gross subtype. In contrast, non-granular sugar-depressed LSD can be the best indication of colorectal ESD because of very high risk of submucosal cancer. Let's see several cases showing the role of LSD subtype analysis. In real-time histological diagnosis. So this is typical granular homogeneous LSD, which suggests negligible risk of submucosal cancer. And which means this tumor may be benign. And NPI image can increase your confidence level for real-time histological diagnosis, in addition to the predicted diagnosis by LSD subtypes. So LSD subtypes suggested benign tumor, and let's see NBI image. So NBI image also shows very regularly arranged and very regular thickness microvessels, surface microvessels. So this is basically genotype 2A and gross type is granular homogeneous LSD. Both features suggest benign adenoma. So the possibility of benign adenoma is very, very high. And so in this, as I said, in this case, we can perform piecemeal mucosal resection. And I also performed the piecemeal mucosal resection, and the final pathology was benign tubular adenoma. Let's see another case. Please think of which MBI, which LSD subtype this tumor is. And please see carefully the MBI pattern. So this tumor is basically a non-granular, flat elevated LSD, which has basically about 5% risk of submucosal cancer. And the MBI image, you can see the vascularity is throughout all the circles, but the arrangement is quite irregular, slightly irregular. So I think the gross type is non-granular flat elevated LSD, which has about 5% risk of submucosal cancer, and the MBI pattern is genotype 2B, which suggests the risk of mucosal or superficial submucosal cancer. So we suspect that this tumor may be early cancer, mucosal or superficial submucosal cancer, and because of the considerable risk of submucosal cancer, we can consider ESD in this case. And I also performed ESD for angular resection of this tumor, and the final pathology was superficial submucosal cancer with submucosal cancer invasion depth of 500 micrometer. Now let's see differential diagnosis by gross features on the white light examination. So there are several white light features suggesting deep submucosal cancer, which include localized redness, firm consistency, hardly spilling, and expangi growth, and broad convergence and deep depression. So this tumor looks very hard. Because of the hardness of this tumor, the tumor does not change its morphology according to the air inflation and air suction. You can see the morphological change of the background soft normal colonic wall according to air inflation and air suction. But this tumor does not change its morphology because of hardness. So in this case, you can suspect deep submucosal cancer. And these tumors show expansional growth at the center of those tumors, which also suggests deep submucosal cancer and fold convergence and deep non-structural central deep depression or ulcer also suggests deep submucosal cancer. And non-lifting sign also suggests deep submucosal cancer. Now let me briefly touch about P pattern analysis and EUS. So this is type 4, a very regular P pattern, which suggests the possibility of benign adenoma. In this case, we can perform piecemeal resection, and the final pathology is benign tubular adenoma. And this P pattern shows a little slightly irregular P pattern compared to this. So in this case, type 5I, a slightly irregular pattern suggests the possibility of a mucosal or superficial submucosal cancer. And in these cases, we should perform EST for analog removal, and the final pathology is superficial submucosal cancer. And this case shows complete absence of any definite, clear P pattern. We can see P patterns in these cases and these cases, but here we cannot see any definite P pattern. So this case is type 5N, non-structural P pattern, which suggests deep submucosal cancer. And in this case, we should perform surgery, and we also and the final pathology is deep submucosal cancer. ES also can be very helpful, but I will not mention in detail today. I think the most important thing about EUS is your expertise level for EUS. So if you are an EUS expert, then EUS can be very, very helpful for detailed assessment of cancer invasion depth and lymph node involvement. But if you are not very good at EUS, then the inter-observer variation is very high, so EUS may not be very helpful. Okay, now let me show you several cases, and I will wrap up my talk today. This is a very huge LSD, and the subtype of the gross subtype of LSD, this LSD is granular homogeneous LSD basically, and which has a negligible risk of submucosal cancer, which means the benign lesion possibility is very high, even though very big size. And the MDI also shows very regular thickness vessels and very regular arrangement of vessels. So the MDI pattern is JNA type 2A, which also suggests the possibility of benign lesion. So the predicted histology, the real-time histology, predicted histology may be benign adenoma. And so I performed piecemeal mucosal resection, and the final pathology was benign adenoma with focal high-grade dysplasia as predicted. This is another case. This is basically a non-granular pseudo-depressed LSD. You can see pseudo-depression at the center of this lesion. And so this gross subtype has about basically 30% risk of submucosal cancer association. And let's see the MDI pattern. So you can see small vessels, brown-colored vessels here, but you cannot see very regular arrangement, which means slight irregularity is seen here. And so this tumor, the MDI pattern of this tumor may be JNA type 2B, which suggests mucosal or superficial submucosal cancer. So, as I said, because of considerable, very high risk of submucosal cancer association in non-granular pseudo-depressed LSD, ESD is the ESD should be considered in this case. And I also performed ESD for complete angular resection, and the final pathology was a superficial submucosal cancer with submucosal cancer invasion depth of 600 micrometer. This is another case. Let's see this tumor. In white light image, you can feel a little hard feeling in this case, and you can see the central non-structural depression at the center of this tumor. So these features suggest the possibility, the risk of deep submucosal cancer invasion. And let's see the MBI pattern. So this is also quite difficult. This is, I think this is also somewhere between JNET type 2B and 3. So I'm not sure. I cannot say confidently about the JNET type, but yeah, it is between JNET type 2B or 3. But personally, in my experience, yeah, the thickness is more severely irregular in this case, I can say, and the arrangement is also very severe. So I'd like to prefer JNET type 3 rather than type 2B in this case, but basically it's quite difficult. Anyway, but the gross lesion showed the characteristics of deep submucosal cancer invasion, hardness and central depression. So I predicted that the real-time histological diagnosis may be deep submucosal cancer, and the final pathology was also deep submucosal cancer with submucosal cancer invasion depth of 3,000 micrometers. Let's see this case. This case this also looks very hard and also has central depression here. So these and also suspected fault convergence here. So these features suggest deep submucosal cancer. And MBI pattern, this is definitely JNET type 3, very irregular MBI pattern. So all these features suggest a deep submucosal cancer or more advanced one. So we performed surgery, and the final diagnosis was even proximal invading cancer in this case. Let's see next case. Do you see any difference between this tumor and these tumors? So it looks a little hard, but these tumors look relatively soft. And although there is no MBI image because of the high resolution of current white light endoscopies, you can suspect, you can predict the vessel pattern. So in this picture, regular vascularity is not seen compared to these tumors. These tumors show red, relatively regularly arranged vessels. So maybe this tumor shows JNET type 3 MBI pattern, even though this is not MBI image. So this tumor may be deep submucosal cancer, and the final pathology was deep submucosal cancer with submucosal cancer invasion depth of 1,500 micrometers. This is 10th case, huge non-granular flat elevated LSD, which has basically about 5% risk of submucosal cancer. And MBI image shows the presence of vascularity or the tumor surface, which means there is no definite avascular area. And but the vascularity is quite slightly irregular. So this may be JNET type 2E rather than 2E, which means there is a risk of mucosal or superficial submucosal cancer in this case. So I performed ESD for angular resection of this tumor, and the final pathology was superficial submucosal cancer with submucosal cancer invasion depth of 100 micrometers. Yeah, this is my final case. This is typical granular nodular mixed LSD. which has about 10% risk of submucosal cancer. And this large nodule here shows a little hard feeling, and the MDI image shows JNET2B or 3 MDI images, which suggests the possibility of early cancer, maybe submucosal cancer. But the other fine homogeneous granular area here, these area looks quite soft, and these areas show very regularly arranged, regular thickness surface vascularities, like these pictures shows here. So these fine granular homogeneous area may be benign adenoma. Anyway, because of the suspicion of early cancer here, ESD for all this tumor may be a good treatment option. But I think there is another treatment option. Because, as I said, this fine granular area shows no evidence of cancer. I performed several times of piecemeal resection here, and then finally, I removed this large nodule area as a single one piece. And I sent the resected tumor to the pathology laboratory as 2 specimens, like these pictures show here. So this fine granular homogeneous area showed benign velotubular adenoma, and this large nodule showed superficial submucosal cancer, and the deep resection margin was clear, but the lateral resection margin was positive. But the lateral resection margin was involved by benign adenoma. The lateral resection margin was not involved by cancer. So I think this planned piecemeal mucosal resection in this case might be curative in terms of cancer treatment. Okay, I'd like to summarize my talk and conclude my talk. For accurate endoscopic diagnosis of early colorectal cancer, we should use various endoscopy methods, such as white light colonoscopy observation for gross feature analysis, and we should use image-enhanced endoscopy, such as NBI observation for surface vascular pattern analysis, and we can use chronoscopy observation for accurate peak pattern analysis. Thank you so much for your time.
Thank you, Professor Jeong-Sik.Byeon, for the informative lecture and so many great case stories. Because limited of time, and we should leave the answer question and discussion at the end of the program. I know that everyone has a lot of questions for the professor, and now we would like to welcome Dr. Nguyễn Thế Phương from Bạch Mai Hospital to share one early esophagus cancer case. Let's see his case and discuss together. Please start your case.
Hi everyone. Today I'm very happy to see my big teacher is Kenshi.Yao. Although the first time I see you, and and now I practice your protocol as protocol daily, and I can introduce my student to this protocol to take the gastric cancer, early gastric cancer. And so we call this not as protocol. We call this protocol is Yao protocol.